And I had the pleasure, absolute pleasure, of meeting our next speaker at the Windrush celebration held at the Prime Minister's residence this summer. And I immediately knew that I had to invite her to be a part of this fantastic gathering to impart her knowledge. Dr. Stacy Bryan is a consultant gynecologist and gynecology oncology surgeon at Imperial College NHS Trust. She is also the chair of the British Caribbean Doctors and Dentists Association, a role which allows her to actively be an example to and raise the aspirations of the younger generation. Dr. Bryan believes in the importance of health awareness and improving health literacy within the community. She works closely with charities and community organizations to provide education surrounding women's health, particularly to those marginalized in society. Dr. Bryan was recognized for her work at the inaugural Black Healthcare Awards, where she was awarded Oncology Clinician of the Year in 2024. Please welcome Dr. Bryan to the podium.
Thank you very much for that. I'm now feeling the pressure as well after all of that, and also on our previous speakers, which were absolutely amazing. So, thank you everyone. Thank you for the organising team for inviting me as well to speak to you today on Ancestry, Awareness and Action, the prevention conversation. And I'm speaking more from the UK diaspora point of view, essentially. I'm a consultant gynecologist and women's cancer surgeon and also a community health advocate, and I'll go into some of the stuff that I've been doing. So, when we think about sustainability, usually we think of sustainability in terms of economic sustainability, financial, but actually I'd like to say that true sustainability really begins with us and our health, because of course, if we're healthy, if we preserve our health, we're preserving our communities, but also future generations. So really, sustainability begins with people, not just policies. Our health determines our capacity to innovate, to build, and as I said, to sustain as well. And I think we need to think about in today's conversation moving from survival to actually thriving. When we look at the ancestry conversation, our ancestry is more than just genetics. It's about our culture. It's about this word resilience that we've heard a lot throughout this conference, about migration. I have to bring into it, of course, the slavery discussion, the colonization discussion, the migration, and actually what that has done to us as a people. Because the stories that we hear about slavery, colonization, inequality, etc., unfortunately has effects on health as well, and opens up the health disparities that we're seeing, particularly within the UK. So we know about high blood pressure, for example, being quite prevalent, diabetes, prostate cancer, breast cancer, and other cancers that affect us disproportionately. It's not just about the biology as well, it's the social determinants. It's where we live, the food that we eat, how we access care, and the trust that's placed in the healthcare systems, or mistrust even. So I mentioned that these, things that have happened in the past, slavery, the colonization, etc., migration, does have an effect on our health, and this has actually scientifically been proven. So Arlene Geronimus is a professor in public health in the United States, and she studied maternal and infant outcomes in black and white women and noticed that there was a disparity. And what she found was that due to racism, social, economic, and political oppression, it actually causes what we call weathering, so changes to the DNA. And that is why there seemed to be some disparity in the outcomes, in medical outcomes. Now, since then, other people have also looked into this and looked at it at other health outcomes and not just related to women. And there is a suggestion that there are changes at the DNA level, at the cellular level, that are occurring, which means that we're more at risk of these types of conditions. But also, unfortunately, because DNA, of course, we pass this down to generations, it's inherited. And are we passing down these changes in these DNA, this stress actually, and the oppression, physically passing this down throughout the generations? So that's something that we need to be aware of, and stepping right back to how do we kind of change that, and how do we look after not only our physical health, but the mental health as well. We also need to look at the legacy of inequality. I mentioned already historic mistrust. Generational trauma and mistrust of healthcare systems do exist. There's underrepresentation in research and clinical trials, but again, we have to understand the history, the medical exploitation, the most infamous one being the Tuskegee syphilis experiment. For those who don't know, over 600 men over, I believe it was 60 years. It was only supposed to be 6 months, but these men were informed that they're taking part in some sort of health improvement study. And actually what was happening back in 1932 is that some of these men had syphilis and were left untreated because the study was just looking at what happens with untreated syphilis, essentially. And what happens in untreated syphilis is deafness, blindness, mental illness, and heart disease. Now, around that time, the treatment, which is penicillin, common antibiotics, was freely available, fully available. But the whole point behind that study is, as I said, is to see what happens. Completely unethical, completely, the basis of why we have so many ethical challenges with research, etc. today. And unfortunately, it meant that because these men didn't know they had syphilis, they were passing it on to their wives and also children. Again, that handing down of these things to the generation. So we have to understand that, and we do understand that as medical professionals, the legacy of this mistrust and this medical exploitation. And the idea behind what we're trying to do is rebuilding this trust, trying to increase the representation, trying to increase inclusion as well. So how do we change the narrative? For us, we think that, education is key, and representation. I think it was Eric that spoke to representation with regards to the younger people in authorship and writing books, etc. For a long time, health campaigns have been built for communities, but not necessarily with communities. And it's about taking things back to the community and building campaigns that are culturally relevant, that are community-led, and understood by the community. Culturally relevant education, delivered by people who look like us, and understand the experiences as well, not necessarily just for us. As we said, the role models, the representations, the building trust is very important. And with the organisation that I work with, and I speak a little bit more about it in a bit, wanting to move from fear-based messaging to empowerment and dialogue. There are so many messages out there about the disparities, as we say. 1 in 4 black men will have prostate cancer. But black women are 2 to 3 times more likely, it used to be 5 times, 2 to 3 times more likely to die during childbirth. Black infants have poor outcomes as well. We're surrounded by all of these figures that's there. And actually, what do we do with this now? We know this. What is it that we need to do? And how do we move on? How do we empower people and change the dialogue? So moving on to the BCDD, British Caribbean Doctors and Dentists Association, for which I am the current chair and a co-founder of. So essentially what we do, we're a group, as I say, diasporans within the UK. We have about 110 members of our organisation, of which Miss Samantha Trost is part of the audience as well. She's one of our members. And what we intend to do is go into schools, churches, communities, and educate our community about these health ailments, things that they can do to empower them. But also how to access healthcare as well, because we know that not everyone is accessing healthcare. Again, we speak about the historic mistrust. We notice real impact in the workshops that we do. People are quite more open because we've allowed a space for people to be open. They share certain stories, which then means that other people share their stories as well. It means that we can kind of give them the information as to where to go, what to present, where to present, who to tell about their symptoms, empowering them that, if you're not listening to, unfortunately, this does happen as well, that black people are not listened to, knowing where to go and how to advocate for themselves. encouraging early presentation of symptoms, and giving informed choices as well. I've added here as well the Black health legacy. So again, we need to encourage participation in research. Previous speaker spoke about data and not being represented in the data that's here, and really needing more representation with that. The Black Health Legacy are an organisation that have just launched their research study maybe about a month or so ago, and they're taking saliva samples and DNA samples from the Black community. And their studies are looking mainly at sickle cell and diabetes, and is there a trend? What is it? Can we analyse from the data to potentially say that, okay, this is a genetic defect, this is missing. So actually, before the illness becomes, how can we target our diet, our lifestyle, etc.? How do we improve our awareness to know that, okay, this is going to affect us, let's just stave that off, let's prevent any illnesses or diseases from actually happening. So prevention as empowerment. Again, awareness is very important. It's about accessible healthcare and early engagement, as we say. Training clinicians in cultural competence too. Partnering, and again, we've had this, partnerships with governments, with NGOs, with other diaspora organizations as well. And investing in data, as I said, research, and into our populations too. So health as a pillar of sustainable growth. Sustainable innovation must include health equity, as we say. So examples of innovation, when we look at in other, now we bring in the kind of Caribbean and African regions now. We know about people that are hard to reach, or as one of my colleagues has often say, hardly reached rather than hard to reach. But ways in which we can try and reach these communities, for example, mobile screening units. For example, I have a colleague who is a Nigerian colleague who's moved to the Bahamas now and has really set up prostate cancer screening, for example, and he's doing very well there. So move into these types of models where we can have, using the knowledge that we have from UK, US, and going into the continents, and having these sorts of things such as screening units to kind of help to increase people presenting earlier. The data sharing across the continents and cross-continental health research collaborations. I've just come back from an international cancer conference in Cape Town. Unfortunately, my counterparts in Jamaica were also present, doctors in Jamaica, who I've actually been to and visited earlier this year, and I'm going again next year. And we started talking about the disparities in cancer care. I'm a gynecologist in particular. We know that women's cancer, endometrial cancer, so womb cancer in particular, is diagnosed quite late, but more aggressive type of cancers as well. And just by having that conversation, we realized that they also see aggressive cancers. So what's happening in Africa and the Caribbean, can it be translated to the diaspora? Let's share that data, because as we've already said, there's not much information here. We're not represented. So let's go to the places where we are represented to really look at the roots of what's going on. So really want to see encouraging data sharing across the continent and cross-continental health research collaborations. So my call to action to everyone really is basically, we have to acknowledge our ancestry, we have to honour where we've come from, know about the health journeys, and to put a slight spin in terms of, not necessarily about, the slavery and the oppression, etc., to put another spin on it, we have been told, I suggest, that Hippocrates is the founder of modern medicine, but actually I argue that is Imhotep. That is Imhotep, who's from Egypt. He was actually the first physician known by name from Egypt, obviously the African continent. So reclaiming that history back as well and realizing that we were the first. Amplifying awareness, so sharing knowledge, challenging myths, normalizing preventative care, and that's what we as BCDD go out into communities and trying to kind of encourage and increase knowledge within our communities. Activating action, so building systems that last. So with that, invest in time, invest in talent and resources, that in initiatives that prioritize wellness and inclusion. As I said, myself being having the links with the University of West Indies, but also we as an organisation were invited to the St. Lucian High Commission a couple of weeks ago to discuss how diasporans can help with a new medical centre that they're setting up. So those talks are ongoing at the moment. So our health is our first form of wealth, so that's why it's very important. Prevention strategies should be our inheritance to the next generation, not the struggle anymore, not the, we should be moving to thriving and prevention, and that's what we should be handing down to the next generation. Because our unity across the continents and across the communities is our most powerful tool for change. Thank you very much.